morning, everyone. My name is Gabby. This is Jackson, and we'll be going over degenerative spinal stenosis. So a little bit about the objectives. We will review the definition of degenerative spinal stenosis, or DSS. We'll discuss possible limitations associated with this condition, and then we'll discuss possible interventions during each protection phase. So a little bit of a review about DSS. It's a condition characterized by the narrowing of the spine canal over time, and it can cause low back pain, neurogenic claudication, and it can be exacerbated with extension-like exercises and relieved with flexion-like exercises. And just a backup or a little briefing about what the neurogenic claudication is. It's basically just pain, numbness, or weakness in the buttocks, thighs, and legs that can worsen with walking or standing for prolonged periods of time. All right, so for the first limitation, we have poor postural control. During the maximum protection phase, we'll do exercises such as single knee to chest, supine pelvic tilts, abdominal bracing. And then for the moderate protection phase, we'll do bridging, dead bugs, supine pull downs, and recumbent bite. And then lastly, for the minimum protection phase, we'll do exercises such as bird dogs, quadratus lumborum planks, alternative upper extremity, lower extremity rise on the exercise ball, and then banded diagonals on the exercise ball. So, since we know that pain is alleviated with flexion, patients with DDS tend to compensate with more hunched over postures to help relieve this pain. So our goal in the maximum protection phase is to regain postural control, and we want to educate our patients on ergonomic positioning, such as how they sit in office jobs or they're very sedentary. We want to educate them about frequent positional changes and techniques for proper lifting, pulling, and pushing. So with a single knee to chest, that will help improve flexibility, motor control, and coordination of the trunk and spine. This exercise can also release pressure off the nerve root. For supine pelvic tilts and abdominal bracing, it'll work more on the neuromuscular re-education, connecting the brain to the abs and the pelvic floor muscles, which help stabilize the core. Okay, so for this maximum protection phase, I'll have Jackson perform a single knee to chest. So I'll have him lie supine, and then I will instruct him to bring his knee up to his chest. And then he can hold with both his hands, and then he can just hold it for about 30 seconds, and we'll repeat this 3 times. All right? So next, for the moderate protection phase, we want to focus on stabilization training, also the neuromuscular control and coordination, and then we also want to bring in more strengthening of those core muscles. So during these exercises, we want to ensure that the patient keeps a tight core and engage those core muscles. So for this phase, I will have Jackson do a supine pull down. So just lay on your back. Hold these for me. Hold this. And just like if he was standing up, I'm gonna have him pull down. Make sure you really keep that core nice and tight, and slow and controlled back up. And this exercise can be progressed to sitting and eventually standing up. All right. Lastly, for the minimum protection phase, we just want to focus on maintenance of our progression, of our progress, and just really getting the strength, and also focusing on doing those exercises during different phases. So not just laying down, but also standing up, sitting, just so it can translate to more functional, everyday ADLs. So with this exercise, we want to work on posture during dynamic movements, like I said. So we'll perform diagonals or PNFs with resistance bands, and that can be progressed. So it can be sitting first, and then it can be progressed to on the ball. Also, I have quadratus lumborum planks specifically because according to Keisner and Colby, the quadratus lumborum is an important spine stabilizer in the frontal and transverse plane, and it's the strongest activation of the muscles in the side plank position. But for this minimum protection phase, I'll have Jackson do some diagonals on the ball. So you just sit for me. And like I said, we can do some P&F patterns with this, so you just hold that. First, I'll do it straight for you. I just want you to take both the bends. So being on the ball will just add some instability. It really helped him engage his core. Right. All right. And that is it for core posture control. And here are just some depictions of the exercises we did. This is the quadratus lumborum plank. This is another exercise that you can do on the ball where it's upper extremity, lower extremity alternating.
Okay, for our next limitation, we have decreased balance and stability. In the maximum protection phase, we'll want to do some upper body ergometer, translational stabilization exercises, the drawing in maneuver. Moderate protection phase, we'll do some bridging exercises, body weight trunk stability, regional resistance training, and then in the minimum protection phase, we can progress to treadmill walking, specifically in an incline. This will put our patient in a more posterior tilt exercise inherently, which will be most beneficial for these patients that don't need to get into excessive anterior pelvic tilt or lumbar lordosis. And then upper extremity loaded trunk stabilization exercises and farmer carries. We've got some depictions. I'm sure we've all seen in the clinic people doing the upper body ergometer, but this will help with stability training early on when the patient might not be able to use a lot of like lower extremity exercises without feeling pain. So this will be a good way to start engaging core muscles while they work their upper extremities as well. But I'll go ahead and demonstrate the drawing in maneuver. This will be an important exercise to teach our patients early on because this is actually one that we'll incorporate into other exercises as we go. This exercise is similar to a posterior pelvic tilt, but it's specifically focusing on engaging your core muscles and your glute muscles. This will shift your pelvis into a posterior pelvic tilt. And this is something we'll instruct our patients to do before a lot of exercises later on in the program. So one way to tell your patient to do this is to ask them to contract their core muscles. You can give them a tactile cue. You can also tell them a verbal cue like bring your belly button back into the table. And then you can tell them to contract their glutes by telling them to either press their feet into the table but don't bring your hips up, or you can just tell them that they just need to squeeze their glutes. And you can tell this is working by either visually looking underneath or putting your hand underneath their lumbar spine, and you should feel their lumbar spine pushing into the table or see that gap close from their lumbar spine into the table. So you just ask your patient, can you draw your stomach into your spine? And can you squeeze your glutes all together? And you can feel back behind their lumbar spine to see if that space is closed. Okay, good. For the moderate protection phase, you can start moving into a lot more like plank positions, bridging exercises. So specifically, we'll do a bridge real quick. This is one that's important to incorporate the drawing in maneuver and then moving into a glute bridge, and you can hold it in that position and just tell them to hold that abdominal like bracing at the top and squeeze their glutes at the top. So you can instruct your patient to push your belly button into your spine, squeeze your glutes, and raise up and hold it. And you can progress this with weight, extra sets and reps, and even protuberations at the top. Okay, good. And then for the maximum protection phase, this is just a picture of the treadmill walking. You can kind of see that you put your patient more into a hip flexion moment so their pelvis is rotating backwards. This is the upper extremity stabilization exercise. Do we have phone? We'll do it on phone. This involves a lot of trunk stability as well as balance training. And you can instruct your patient even in standing to perform the drawing in maneuver before they start this exercise. So I just want you to contract your abs, squeeze your belly button into your pelvis, and then or in your spine, and then squeeze your glutes. And all I want you to do is get a good bend at your knees and pull that band out. And you can progress this with more unstable surfaces, protuberations at the top, and this will incorporate a lot of ab contraction in all the layers to make sure that the trunk stays upright. For our next limitation, we've got limited trunk and lower extremity flexibility. It's important for these patients to have flexibility in their hip flexors. And it's also important to get some paraspinal stretches because these being tight can put the patient in a position of anterior pelvic tilt, which would exacerbate their symptoms. In the moderate protection phase, we've got hip extension, active range of motion, and lumbar flexion, active range of motion. And then for our minimum protection phase, we've got the Williams flexion exercises, which have been highly studied specifically for patients with degenerative spinal stenosis. So I'm not going to demonstrate the psoas release. That one's been done plenty of times, but I will show y'all the rectus femoris stretch. Now this is one that you can, especially in the acute phase, the minimum protection phase, you can alter if your patient is like overly kyphotic, which is commonly seen, the hunchback position with these patients. So sometimes you might have to do this exercise or this stretch in side lying or in prone. So I'll actually show it in side lying. If you want to face, what's better, her facing that way? I'm going to bring her leg back towards me.
Facing me.
Okay. So since the rectus femoris crosses the hip and the knee, it's important that you have a stabilization hand to make sure that the pelvis doesn't move into an anterior pelvic tilt, because the patient will probably feel symptoms in this position. So it's important to have a stabilization hand at the hip, and you can do some knee flexion and hip extension, which will stretch the hip flexors and more specifically the rectus femoris. Okay. All right, you can stand up. For the moderate protection phase, we can do some more active range of motion. I'll demonstrate the paraspinal stretch, active range of motion, lumbar flexion, active range of motion. So you can get a wall, or you can have your patient come up to the table. Can you stand on the side too? You can turn and face up. This is the back of the table is just a place for your patient to have some kind of stability. But I'll show you this one first. This is an active range of motion. You're just bending down towards your toes. You can instruct your patient in the moderate protection phase to move as far as they can without feeling pain, and that be their limit. And they can just go into active range of motion and back out. So just reach down towards your toes to where you feel a little stretch, and then come back up. Okay, for the Williams flexion exercises, there's a lot of literature behind these exercises, and you can progress these in a lot of ways with weights, with resistant bands, with unstable surfaces to perform these exercises on. We'll do the first two, but there's a whole list. Y'all can check out the PowerPoint afterwards, and there's a ton of literature on this, so y'all can look it up as well. But the first one's just a pelvic tilt exercise. You can instruct it very similar to the drawn in maneuver, but you can make this one an exercise that they're repeating over and over again in this phase. So I just want you to draw in with your stomach and just feel, yep, push your back into the table. And then the next one is a sit up in a knee flex position, so you can stay in this position. I just want you to bring your chest up to your knees. Good. And all of these Williams flexion exercises are good for opening up the intervertebral foramen, that canal, to where your patient will get relief and still work those core stabilization and global stabilization muscles. You're always...
Are there any questions?
The stabilization hand you were using for the rec film and the stretch, that's to avoid any symptom reproduction, not to like increase the stretch, correct?
In the sideline position, yes, correct. You're simply holding it there to make sure it doesn't move, the lumbar spine doesn't move into excessive lumbar lordosis. Because normally to stretch the rectum, you would be doing a stretch in supine and like coming down this way. But it's just a little harder to stabilize the pelvis in that position.
I forget the exercise where you put supine, you put in the band.
Mm-hmm.
Curious, where did you feel that? What muscles?
Oh, that's a lot of lat and core stabilization muscles.
Yes.
Can you make the drawing maneuver function?
Well, you need to do that when you're walking, when you sit up from a chair. So you have to have stabilization in those core muscles so you just don't fall over. So it's necessary for every day-to-day task that you have to get up for.
So I have a patient with considerable amount of abdominal adipose tissue. And if they have difficulty with reaching their hand to pull their leg back, what can you do with a patient in that case?
You can get a band or like if they're at home, they can get like a dog leash, but it'll help them pull it to themselves.
You all mentioned the rectus femoris muscle. What two special tests can you use to assess the extensibility of my rectus femoris muscle?
Yep, you can do Thomas says ELOS test.
What would the Thomas test look like for a positive rectus femoris?
Yeah. This is one where you instruct your patients to bring their knees up to their chest and they're bringing one leg down off of the table, just like this. Is this a ELOS test?
That's
Okay,
right.
right.
What would be a positive rectus femoris? And I think it's positive.
Maybe positive.
Yeah, so for specifically for the rectus femoris, you would see then instead of the knee being in a flex position, it would be in a more extended position.
Could you see that on the rating exam?
Yes.
Probably.
See that on the national physical exam?
I can see it.
Could you see that on the lab